all the time, and it's definitely possible. We know that the ozone layer is thinning, and so more ultraviolet rays are reaching the Earth's surface than previously. I think, I mentioned this tanning salon. I think that's a huge part of it. I think, unfortunately, young women and men are getting increased exposure to tanning salons at a young age, and we know that exposure even one time can really increase your chances, so that's why we're trying to get the word out there. Is it changes and reduction in the immune system? I think, as Dr. Pavlick mentioned, the immune system is very important for tumor regulation and trying to keep your body in check and prevent cancers. I think that's more on an individual basis. I don't think as a whole the society is suffering from immune deficiency, but maybe you want to comment on that?
No, I agree. Everybody takes different care of their bodies, and I don't really think that the world in general has an immune deficiency state. We know that with certain cancers like melanoma, your immune system can be decreased, and so if we find ways to upregulate it, we may be able to get better control of your tumor.
Okay, so I got a long question here, but I'll try to answer it briefly about the use of sunscreen and how in the 70s and the 60s people did not promote sunscreen and the awareness about it, and I think this is also important. We just heard about from our survivor. I think really it's important to educate children early. Certainly, even when I was growing up, using an SPF of 15 sounded so high. People would put on SPF 2 or 4 or baby oil. So the question that was asked and that often comes up is, how high do you really need? Because if you look at Duane Reade, you see numbers going up to 70, 85, 100 plus. Is there really a number that's too high? The answer is that if you adequately apply an SPF 30, you are blocking about 98% of damaging ultraviolet rays. And above that, it does make very little difference. But the issue is people don't often apply enough sunscreen to achieve the SPF that it says on the bottle. So people, as I mentioned, might put a tiny pea-sized amount on and think they're covered for the day. And you really need 2 milligrams per square centimeter, or as I said, a shot glass to cover all exposed areas. So the reason I like the higher SPF numbers is it's sort of a little bit of an insurance layer of protection. Maybe if you're not applying as much as you should to achieve that SPF, the higher numbers kind of add that level of safety. So I do wear SPF 30 every single day, but I go up to SPF 70 or 80 in the summertime.
I have one question where someone asked, how long is experimental drug therapy required after regression of the tumor? And I really wish we had a good answer for that, but the answer is we don't know. Many times when we put people on investigational drugs and we get the tumors to completely go away where we can't see them on scans, the question arises as to how long do we continue therapy, and the answer is we don't know. Many times what will happen is some of the therapies will give patients side effects, and when the risks outweigh the benefits of the drug, that's when we make a decision, patient and physician, to say, okay, you know what? I've got no more melanoma on my scans, but every time you give me this drug, I get very sick, so it's time to stop. And that's many times how we make that decision to stop. And for drugs that may not give patients side effects, many times we don't stop the drug.
Since I don't have many questions, Dr. Hale gave me one so I wouldn't feel left out. The question reads, bluish green spot on the sole of my foot. It's hard always to answer something like this without actually seeing it. And I think that if there's something that you should have gotten out of all of the talks here is that melanoma is a type of cancer that doesn't necessarily obey the rules as it's written in the textbook. So whereas we could describe the classic picture on the ABCDE pamphlet that you have, anything that is not typical or anything that changes should be evaluated by first your dermatologist because it's hard to exclude it based just on a description like that. So whereas it doesn't fit our classic criteria, it certainly doesn't rule it out. And I think we all agree that you have to be careful, particularly with melanoma. So that's my answer, is to have it checked out. I don't know if Dr. Hale would agree or disagree, but I'll give it back to her.
I always agree with you. If it's been there for a long time, it very likely could be okay, but I agree, it should be looked at and investigated. I have several questions, so I just tried to sort of group them together in the interest of time, because I know we all spoke over our limit. Just some general questions again about sun protection factor. SPF refers to the ability of a sunscreen to block ultraviolet B rays, which are the burning rays. And so increasingly now there's more data that we should also protect against ultraviolet A, because UVA rays can age the skin as well as contribute to development of skin cancer. And UVA rays are actually longer wavelength than UVB, and those are the ones that penetrate through glass windows and car windows, which is why when you're choosing a sunscreen, you want to find one that blocks both UVA and UVB, so you can look for certain ingredients that are broad spectrum. Someone asked if it's bad to only use an SPF of 15. If applied adequately, so again, if you get that 2 milligram per square centimeter, SPF 15 does block more than 95% of rays, but you should definitely reapply. I think a minimum of 30 is recommended. As far as specific brands, I really think it's most important to just look for something that you'll actually use. So if you're acne prone, you might want to find one that says oil-free. I tend to like the sport sprays in the summertime, so I'm very active. I run outside every day, but I spray my chest literally every hour with the higher SPF. So I'm not going to recommend specific brands here, but someone asked about eczema. You know, again, you might want to try different types that are non-irritating, that are fragrance-free. And someone asked about eczema causing skin cancer or being a precursor. Eczema itself does not predispose you. However, people with really severe eczema or psoriasis often find that they like the effect the sun has on their skin. So those people may be at an increased risk just because they're seeking more sun. And again, an isolated patch of what's thought to be eczema, like the scaly patch that doesn't go away despite hydrocortisone cream, that should be biopsied, because that could actually not be eczema, but could be something like a squamous cell cancer. As far as techniques to diagnose melanoma, I really think the bread and butter is coming in and having your skin checked by a dermatologist, or someone like Dr. Pavlick, who's excellent also at doing skin checks, although she doesn't have time. But really a well-lit room. But most dermatologists now, at least I can speak for myself, we carry something in our pocket called a dermatoscope, so it's really like a magnifier that can help to look at individual moles. Some patients that are really high risk, and there's another question about that, patients with multiple dysplastic nevi, it often helps to follow those patients photographically. So I have patients get their moles photographed, and they'll bring their album every time they come in. So if I'm looking at a mole, and if it's changed since the last visit, I will biopsy, because again, change or evolution is the most important. And then there are some really newer tools that allow us to look at each mole with a dermatoscope and computerize that, and the computer can help detect changes. This is really just available this year. This is sort of like the new wave of melanoma detection. Briefly about blue light and red light treatment. Yes, I do this in my practice every week to treat actinic keratoses and some non-melanoma skin cancers. I mentioned that sometimes you can feel a rough patch, and that might be a precancer or an early squamous cell cancer, but people that have sort of their whole face covered, a lot of people that spend time outdoors, or older individuals that have confluent precancers, and it's just too much to treat each one individually. We often do procedures like photodynamic therapy, where we apply a chemical to the whole face. That chemical gets selectively picked up by abnormal cells, and then we shine a light, either blue light or red light or some combination, to destroy those cells. And I'll turn it over, and then I'll come back to answer.
Okay. Since I have one insurance question, which is the bane of my existence, it's Metro Plus Medicaid. So what we do is we refer our patients to our legal. We have a woman from NYLEG, the New York Legal Association, and New York Legal Group, and she will help patients to get into regular Medicaid, because a lot of the doctors do not take managed Medicaid. Some take regular Medicaid, and we would help to expedite that with the attorney.
One actually that is related to surgery. If a person has a history of malignant melanoma, status post-wide excision of a thin lesion, what should the follow-up be with the surgeon and the dermatologist? So again, the thinner the melanoma, the less intense a follow-up has to be with the surgeon, because from my perspective, what I'm looking for is I'm there to see that there's not a recurrence of the cancer that was excised. So I'll look at the primary lesion where the excision was, do a full lymph node exam, do a cursory exam to make sure that there's nothing that's evident for any spread elsewhere, although unlikely. The dermatologist, and I'll tell people that, again, the dermatologist visit is exclusive because their main focus is to make sure that no new melanomas develop. So I'll let Dr. Hale say what she recommends. I usually recommend that anybody, regardless of their thickness of melanoma, see their dermatologist at least 4 times a year for the first few years at least after the diagnosis, and really resign themselves to lifelong skin screening. As far as my particular follow-up, it depends honestly on how good their dermatologist is. If they have a good dermatologist like Dr. Hale, I'll be comfortable with them seeing them twice a year. If it's somebody who I don't honestly think is doing a full skin screening or surveillance, then I'll probably see them up to 4 times a year. But for a thin lesion, I typically will see them twice a year after the initial post-operative period is over. I don't know if you have any comments on that.
Yeah, I agree with that. When someone has a newly diagnosed melanoma, I'll see them every 3 months for 2 years, and then every 6 months for the rest of their life. And if someone has a basal or squamous cell carcinoma, every 6 months for the rest of their life. If someone has a first-degree relative, I'll also see them every 6 months. And then patients with dysplastic nevi or atypical moles are really specific high-risk subset. I'll see them more regularly, so more like every 2 or 3 months, especially if they've had melanoma.
Great. So we're getting to the end of our program, so we have time for 2 more questions. Don't mean to add the pressure.
Paper, scissors. Well, I think this is for all of us, so I'll read it because I only have one other question. It is encouraging to hear about more visibility about skin cancer in some major cities, but why is there so little out there in the way of public information campaigns, particularly given the opportunities for prevention and early detection? And it's a great question. Obviously through Molly's Fund and what we see here today, we are getting the word out. Often, honestly, it depends on its visibility at the particular time, and it's sad, but when there's a public figure who gets a certain type of cancer, it raises public awareness. When John McCain was running for president, we were all getting questions asked all the time by the press about melanoma, but it's kind of receded a little bit since that time. But I think it's up to all of us, everyone in this room, to help get the word out in that. And I'll pass it on to anyone else who wants to address that.
As we all mentioned in our presentation, I believe that the best way to raise awareness for safety and prevention is through our children. And like I said, there's a fine line between, scaring the bejesus out of your kids and making them aware of the risks that are out there, like the risks for smoking, like the risks for alcohol consumption, things like that. Sun prevention should not be taken any less lightly than those things. So my goal as a survivor has been to raise awareness in whatever way that I can, by talking to different groups about melanoma, by talking to the children at the schools where my children attend. But you can all be ambassadors for sun safety and skin cancer prevention by speaking to the children in your lives, speaking to the people in your lives. If anybody uses a tanning bed, that's just a no-brainer. That should not be happening, as far as I'm concerned. So use this opportunity yourselves to raise awareness from all the things that you learned today. I had a quick question. Primary melanoma internally, how common is that, and how can one be screened for tumors not visible? In the interest of full disclosure, my tumor presented 18 months before I did anything about it, and it was poking through my skin essentially as a hernia would. So it wasn't a fact of like the melanoma grew inside of me and I didn't know anything was going on. I just chose to take a head in the sand approach, and I'm doubly fortunate that I'm here today to regale you with that beautiful story. So it's very unlikely, I would think, but Dr. Pavlick can back me up on that. You would need a CAT scan obviously to find if you had cancer internally, but generally it presents on the skin. Yeah, or it presents as a tumor that is poking through your skin.
Yeah, when we talk about primary melanomas are the melanomas that happen on the surface of the skin. There are rarer types of melanomas that can grow either on the bottoms of the feet, the soles of the hands, like Dr. Hale talked about. There are other types of melanomas like ocular melanomas and mucosal melanomas that can occur in the sinuses or within the mouth that, again, on examination we find. But when you talk about primary melanomas of the skin, they happen on the skin, and there are cases where patients will just present with an enlarged lymph node and will never ever find where their primary came from, but we know it started somewhere on the skin.
Okay, great. I want to thank all of our wonderful speakers today for giving their generous time to this outreach effort. We'd like to thank the Molly Brigade Foundation for their generous support of today's program, and we'd like to thank all of you for coming. So please join us for lunch. Wear your hats, wear your sunscreen, and we hope to see you next Thursday at our free skin cancer screening here in the hospital. Thank you.